may. We might not get to the diagnosis. We might not even say the diagnosis in the whole hour, but we will hopefully learn a lot in the process about how to think through each step. So with that, Maria, would you like to tell us the chief concern, chief complaint in as few words as possible?
Yes, of course. The chief concern is going to be memory loss.
Memory loss. Okay. Sakhi, do you want to just tell us what comes to mind when you hear memory loss? How would you start thinking about that?
So the first thing I think about memory loss is, I think age. What's the age of the patient? And the progression. Is it acute? Is it subacute? Or is it chronic? I think that's what it, and is it slowly progressing or is it fast progressing? I think these are some of the most basic things that come to my mind.
Fantastic. Those are all great things to be thinking about. And so I totally agree with you. The time course here and the age are going to be very important. How will those, when we learn them in the HPI, how will those influence what you're thinking? So you said, is this acute, subacute, chronic? How will those help you think through this case?
So I think when I'm thinking acute, just an acute onset of memory loss, I would be thinking of something that's typically, well, it's just going to be atypical. It's not going to be things that we see day to day. I would be thinking about toxins. I'd be thinking about some atypical infections. I'd be thinking about toxicity with, all the different things. And when I'm thinking subacute, then maybe some sort of an autoimmune process, some sort of an inflammatory process. And if I'm thinking about chronic, then it would be, I don't know, chronic with age is the most obvious would be dementia. But apart from that, I don't know. I mean, most common would be also depression, I guess. But yeah, these are some of the things that come to my mind. Fantastic.
Yeah, brilliant discussion. Exactly. So I saw, is it Valeria wrote, tempo is queen. I love that. So we like to say in neurology, as everyone here has heard me say many times, that differential diagnosis equals localization and time course, right? So memory loss, we know the localization is in the brain. We're not going to have to figure out, like our diplopia one, is this in the 6th or 3rd or 4th cranial nerve or the muscles, neuromuscular junction, pons, PPRF, all that stuff, right? Here we know we're in the brain, and so we're really going to focus on the time course. And as you said, these are some super important categories to think about. If this is sudden in onset, we might think of vascular etiologies, toxic, metabolic causes. If it's acute but not sudden, we might think about infections that affect structures involved in memory. If it's slower but not fully chronic, so subacute autoimmune etiologies, and we can talk about what some of those might be. And then if it's chronic, as you said, it could be normal age related. Probably that wouldn't be a morning report case, but that would be common, right? Or it could be a dementing process, which could be neurodegenerative, like Alzheimer's, as you mentioned, could be depression, so-called pseudodementia, or many other things. So that's a great first approach here, just thinking, what is the time course? Kirtan, anything to add here?
Yes, so just to add to what you and Sakhi discussed, that we have discussed about the time course, and then we also have discussed about the localization. So now let's zoom in. So now what can cause memory loss? So we know that memory is primarily dealt with hippocampus, limbic system, some parts of temporal lobe, and some parts of prefrontal cortex, which helps in executive functioning and kind of, integrating everything. So what can hit the limbic system or what can hit the hippocampus? So usually stroke is not something we deal with for memory loss, but of course a strategically located stroke in the temporal lobes can sometimes do it. Apart from that, we talked about the acute time course. So what if we come to know that the patient recently developed a fever, and what if the patient has recent sexual encounter? Then we know that herpes simplex encephalitis can classically present as memory loss along with behavioral changes in the acute form. Then we can also talk about the paraneoplastic encephalitis, because they also classically affect the limbic system, so-called limbic encephalitis. So that's how we can localize based on the site of the memory storage in our brain. Apart from the neurodegenerative disorders, so of course we talk about Alzheimer's disease, and we have to talk about the FTLD, that is so-called frontotemporal lobar degeneration, in which frontal lobe dysfunction causes the behavioral changes. So we would like to see in HPI that what are the accompanying changes to memory loss, because if behavioral changes are present, then we can also think about the pathology affecting the frontal lobe. Then what if this is not even chronic and not acute, somewhere in between? So something like subacute. Then we know that Creutzfeldt-Jakob disease can also present as memory loss. Of course, we would like to see whether movement disorders have movement pathology is present or not, and what like myoclonus is present or not. So other symptoms along with the memory loss will guide us a long way in that. And lastly, what are the reversible causes? So what if we find that patient also has, some evidence of gaze disturbance or some kind of visual blurring? So normal pressure hydrocephalus kind of thing. And as Aaron has taught us numerous times, that NPS doesn't classically present with the triad of like gaze disturbance and urinary incontinence. Sometimes memory loss or depression is all you get. So we have to rule out the reversible causes, whether increased intracranial pressure is not driving all this process. So yeah, all these things, neurodegenerative disorders, autoimmune and inflammatory disorders, and metabolic disorders as usual, but they usually won't cause memory loss as per, they would cause kind of delirium or something like that. So let's see what's the time course. And now Aaron, help me, what am I missing here?
Great. Well, between the two of you, we are missing very little, if anything, right? I said the localization is easier here. It's the brain, but you're right. If we want to get very specific, we could talk about what type of memory loss, because memory is not a unitary entity, right? Usually in neurology, when we're talking about memory loss, we're talking about problems with episodic memory, right? When we think of the classic patient with Alzheimer's disease, they're forgetting people's names, they're forgetting appointments, those types of things that are part of episodic explicit memory. So there are all these different ways that psychologists talk about memory, right? Explicit versus implicit, and declarative and semantic, and all these different ways of describing what are things that you can remember. And as you said, we think memory loss, hippocampus, but as you said, Kirtan, there's really a whole network here. The classic circuit, I don't know if I still remember it, the circuit of PAPEZ, P-A-P-E-Z, which is from the hippocampal regions through the fornix, this fiber pathway, to the mammillary bodies, to, someone can help me here if they know it, but I think it goes to the anterior nucleus of the thalamus, to the anterior cingulate, and then back to the perihippocampal and hippocampal regions. And that's for sort of episodic memory, right? But there's this other concept of working memory, which is really part of attention, right? Where and sort of keep track of things. When we're asking patients to count backwards by sevens, we're testing calculation, but also attention, and you have to keep in mind what the task is and where you were, that sort of working memory. So it depends what we mean by memory loss, but usually a patient who's saying they've lost their memory, they're thinking of these sorts of things, that they're forgetting things. And this is usually for recent memory. So this is amnesia, and that localizes somewhere along the circuit. So if we want to get really precise, right, sometimes people say, oh, this patient has memory loss, I'm looking for a lesion in the hippocampus, and you find a small lesion in the anterior thalamus or something like that, and you have to explain why this is, and that's because there's this whole circuit of PAPEZ. It's not just the hippocampus. As you said, we're in the brain, right? We'll have to figure out if we can be more specific based on the pattern of deficits. I think zooming out, right, we'd have to say, is this truly memory loss, right? The patient might say that there's a memory problem, but as one of my great teachers, Marty Samuels, likes to say, for the cognitive modalities, it's like these Russian dolls, you know, these dolls where they're made out of wood, right? And you open the doll and there's a smaller doll, you open the doll and there's a smaller doll. The first doll is attention, right? You can't have memory without attention. So if you're pretending to listen to someone, but really you're texting on your phone, right? And then they say, don't you agree? And you say, it's not that you forgot what they said, you weren't paying attention. So you open this first doll of attention that gives you access to memory, and you need memory to have a conversation, right? Because you're using your working memory to keep track of that. And so sometimes the patient may just be inattentive, and so they're not registering memory. So if you do these tests of 3 words, red, window, honesty, right, or 5 words, face, church, velvet, daisy, and red from the MOCA test, right? When you do these, if the patient has a lot of trouble just registering them in the first place, your memory test is not going to be very valid, right? Because their attention was impaired. So you give them the 5 words, maybe they get 4, they need another trial to get 5. But if they're really struggling to even register those words, you can see there's an attentive deficit there. But presuming it's truly memory loss, right? We want to think about structures in this limbic circuit and what diseases can affect them, right? So you can get a stroke of one of these structures, usually you'll see other stuff, right? So the hippocampus is actually in the PCA territory. So always think PCA territory, visual field deficit. Yes, usually, but the occipital lobe is not the only part of the brain that's in the PCA territory. That whole medial temporal inferior temporal region is there as well. So sometimes patients, the visual field deficit might be difficult to tease apart on the exam, and they can have acute amnesia from a stroke in the hippocampus or in the anterior thalamus. And another acute etiology to think about is transient global amnesia. Are either of you familiar with this condition? Can tell us a little bit about it?
So transient global amnesia, I think I've seen a patient with that. I think it's firstly a diagnosis of exclusion. That's what I've been taught. And the second thing is that it typically lasts 24 to 48 hours, and the patient just blanks out, doesn't remember what happened to them, nothing at all. And then within 24, 48 hours, they tend to remember, they get back their memory, but they don't remember that incident. So that's like a blind spot essentially. Yes. And and I believe the recurrence is not very common, but there are some reported recurrences. So yes. That's what I know about it.
And do you know, or Kirtan, do you know the very characteristic behavior of the patient during the episode? What do they appear like on exam? What are they doing? What are they saying? Yes.
So if I am not forgotten, they don't remember the path that they took. So if you, for example, during our step examinations, we learn that if the patient is in Las Vegas, let's say, and if you ask them how you came here, then the patient won't know, but patient will still have some amount of autobiographical information. So I guess the main difference between dissociative amnesia and the transient global amnesia is this only, that whether loss of autobiographical information is there or not. If you lose that, then it is TGA. If it's not, then it's the other way around. And I guess that's all I remember as of now.
Yeah, very good. So right, so a patient should never forget their name, and that's usually believed to be a psychiatric etiology of memory loss in those conditions of dissociative amnesia. Even patients with very advanced Alzheimer's who have very minimal verbal output will know their name. The very characteristic behavior, so these are patients that suddenly become amnestic, anterograde amnesia, meaning they're not registering new memories. Their remote memory is generally intact if you ask them where they're from, how many brothers and sisters, etc. But it's very sudden in onset. These patients are often triaged as a possible stroke, and their very characteristic behavior is that they keep asking the same question over and over again. It's like they have a tape recorder. I don't know if anyone's old enough to remember tape recorders in VMR, and then it's just a small loop and it just keeps taping over itself. So one of my mentors like to say, you can really learn something about the length of the memory buffer in this condition, because the patient is there and you say, you're in the hospital, don't worry, you haven't had a stroke. And they are agreeing with you. And then in a few minutes they say, where am I? Who are you? What happened to me? Everything is just getting erased every few minutes and then starting from scratch. And yeah, usually the event is less than 24 hours, and they're not making any new memories. They just keep taping over that same loop of tape. They don't remember anything that happened. It's a very fascinating condition. It's usually triggered by either an emotionally intense event, a fight, bad news, sexual intercourse, or jumping in cold water. And in Boston, where it's very cold most of the year, where I spent all of my training and the first 6 years of my career, once it gets nice out, people want to go in the ocean, but the ocean is freezing cold there. So every time around spring, you'd have a case of transient global amnesia. And we said, let me guess, did they go in the ocean this morning? And everyone says, how did you know this? If you do, you should do an MRI in these patients, because you can see a tiny dot of diffusion restriction in the hippocampus. It's not considered a stroke. Nobody really knows why it's there. There's no significance to it, but transient global amnesia is a syndrome, not a disease. So it can be caused by a stroke in that territory as well. I've never seen that, but you can see this little dot of diffusion restriction is the little footprint that something happened to this patient. Anyway, such an interesting condition, and I had never seen it before until residency, so we spend a little time on it. Anyway, yes, toxins, metabolites, drugs, all those things. You mentioned Hsv encephalitis. This is a limbic encephalitis, right? The Hsv infection, I'm not sure why it has a predilection for the temporal lobes and limbic circuitry, limbic regions, inferior frontal lobes, insula, but it does. You mentioned that following sexual encounter, Kirtan, my understanding is that Hsv encephalitis is almost always HSV1, so not necessarily sexually acquired. Most of us have HSV1. If you've had a cold sore, you've got it. And in some unlucky people, it finds its way back along the cranial nerves to the limbic regions. HSV2, which is sexually transmitted, causes genital herpes, right? Can cause encephalitis, meningitis, but pretty uncommon for encephalitis anyway. And then you mentioned the very important category, Sakhi, is at Mayo Clinic, where we all send CSF samples to look for these autoantibodies, right? And limbic encephalitis, such as NMDA encephalitis, one of the best characterized, can often begin with memory loss, psychiatric impairments as well. And then chronically, we all think of dementia, but we have to remember dementia is not a disease, right? It's a syndrome of progressive cognitive dysfunction to the point that the patient can't perform their activities of daily living. So that can be from a neurodegenerative disease, like Alzheimer's disease. That can be from Creutzfeldt-Jakob, which is a prion-related disease, whatever prions are. Some people think they're infectious particles. We don't really know. But can be from other conditions, right? A strategic structural lesion like a brain tumor, subacutely or chronically growing in the temporal lobe, thalamus, something like that. Subdural hematoma, right? Probably not specifically memory loss, but confusion. Mentioned normal pressure hydrocephalus. Those patients are almost always going to begin with a gait disorder and urinary dysfunction before they develop cognitive condition later on. So, okay, 2 words. We've covered a lot of ground. And for those new or new to this or wondering why we do it this way, I think it's always helpful to just really hash out the approach to something, because now as we hear the history, we have a bunch of hypotheses. We all want to know the time course, right? And that's going to narrow our view and what associated symptoms, if any, are there, other neurological, psychiatric, systemic symptoms, the age of the patient, right? The past medical history, all of those are going to influence our discussion, but we sort of laid out the map here and we'll see what direction we're going. Okay, Maria, can we get a few more words for our discussants?
Yes, that was great. And I think this is going to answer a lot of questions. So this is an 82-year-old female who's been having memory loss for the last year. She comes in with her daughter, and they say that she's been found to often repeat herself several times during a conversation. She recently handed her finances and the medication management to her daughter because she was making a lot of mistakes with that. She has limited also her driving. She only drives once a day to church because it was making her and her daughter very nervous. And she's been experiencing sadness and mild depression because she recently separated from her spouse, but otherwise is in pretty good health. I'm going to give you the past medical history as well. She's had a CAD with a triple vessel CABG. I don't remember how you say that, but it's always funny how people pronounce that.
Yeah,
but
people say cabbage like the vegetable. Yeah.
That's right. Okay. Depression. She's been diagnosed with depression and hyperlipidemia. Her medications are aspirin, atorvastatin, sertraline, B complex, calcium, magnesium, zinc. She's widowed and she now lives with her daughter, but previously was living independently. That's what I have for you.
Great. Any questions about the history, Kirtan or Sakhi?
My question is, when did she lose? Do we have a time frame on when she lost her spouse or separated from her spouse? Has it?
No, I do not have that information. Just recently it says.
Okay. And why are you asking that, Sakhi? That's a good question.
I think just for diagnostic reasons, if the person passed away and if she's in grief, just to kind of say if it's pathological grief or if it's, that is one reason why I was thinking. And if it's just some kind of an adjustment disorder that she's suffering from that's causing all of these memory loss. More just to kind of separate if it's psychiatric and what kind of psychiatric issue, or if we're actually dealing with a pure neurological disease.
Great. It was a great question. I wanted to make sure everyone learned from your thought process there as well. Great. I think you're up first, Kirtan. For the time, we'll have you discuss the history and what you're thinking, and then Saki will have you discuss the exam when we hear that.
Yes, actually, just Maria, actually, I missed it. That did the patient had nystagmus? You said something like that. What was that? Apart from depression, anything else?
No nystagmus, no, nothing. Healthy.
Yes. So in the HPI, only we have memory loss, and that's it.
Yeah, yeah. Memory loss, handed over finances and medication management, not driving anymore. Nothing, no nystagmus.
All right, got it. Yeah. So actually, the part where the Maria told us that the patient is not driving anymore because everyone was scared. So that is really interesting, because if I remember correctly, in Alzheimer's disease, this is one of the characteristic feature, because people lose the way around their home. So, you know, the topographical memory, the way our brain organizes the maps in our brain, that is lost in Alzheimer's disease. So that is interesting point. And again, this problem has been present since last 1 year, but it has got worsened recently. So that is concern, because we know that neurodegenerative disorders progress, but this progression over maybe a short period of time, we are not absolutely sure of the time period, because Maria told us we don't have that time frame here. But what can cause acute exacerbations? And now also the medication, usually we look for anticholinergics or something like that, with the patient is not on anticholinergics. So that's reassuring. And so, yes, apart from that loss of topographical memory, there is little that I couldn't think of, because we don't have any other history like some recent stroke or anything like that, which can explain the sudden worsening. Apart from that, I would be also interested to see in the imaging studies, because we know that Alzheimer's disease is basically amyloid kind of thing. And we know that over the time, amyloid can deposit in the blood vessels and can cause all sorts of funny things. Sometimes it can even cause focal deficits, can cause meningeal inflammation, CSF disturbances. So so-called cerebral amyloid angiopathy like inflammation that we discussed in detail during our previous VMR. So that is also one thing that we have to look for in the imaging studies. Of course, I will look for the atrophy. If there is atrophy of the temporal lobes, that can probably suggest that, okay, this is Alzheimer's or related to Alzheimer's. And apart from that, since memory loss is the only thing we have, no changes in behavior, nothing else. So I am kind of, skeptical to think about other degenerative disorders like FTLD or anything like that. We have nothing yet here. So Aaron, now can you help me? What are the things that we should look for or tease out of this HPI?
Yeah, I think it's a great discussion as always, Kirtan. I think, as you said, we're hearing that this has been going on for the last year, but obviously, but how should I say? I was going to say that, so this sounds at least chronic, right? But you said we're not totally clear on the time course, because unless something is truly sudden, right? And presumably if the patient lost their memory overnight or over a week, they would have come sooner, right? It's hard to really pinpoint when these things begin. And with neurodegenerative disorders, in this case, affecting cognition, in the case of Parkinson's, affecting a patient's movements, right? By the time they come to the clinic, often things have been going on for a long time, and this patient's in her 80s, so maybe she was forgetting some things in her 70s, and she said, well, I'm in my 70s, and her children said, you're in your 70s, you're forgetting a few things. But clearly things have progressed to the point that she's no longer able to do her finances and not driving. As you said, Kirtan, one feature we often ask for, people always think Alzheimer's, hippocampal atrophy, that is true, but there's also early superior parietal atrophy, which probably has something to do with spatial awareness and spatial reasoning in interaction with the hippocampus, right? So the story of getting lost in the grocery store, right? All of us go to the grocery store thinking we are going to remember what we want to get, right? And we forget that's normal, but sort of getting very disoriented or getting lost driving to familiar places can be a feature of Alzheimer's disease, right? Or sometimes people just say you're forgetting so much, maybe it's not a good idea that you're driving, even though there is no getting lost. So hard to know exactly how to interpret that. And since Maria is presenting a case that someone else put together, we don't have the other details you might like to know. We just have what's there. So so I agree with you. This is a chronic condition. You mentioned something about sudden worsening. Was there sudden worsening, Maria? I had missed that in the history. No, okay. Yeah, so no clear sudden worsening. And so once we get to dementia, right, this patient has dementia, right, sufficient loss of cognitive function to require assistance in activities of daily living. We have to remember, as I said, that's a syndrome, not a disease. So the first part of our evaluation is, of course, going to be to examine this patient to say, well, yes, there is memory loss, right? And are there other deficits that go along with that? You said, Kirtan, other degenerative conditions like frontotemporal dementia, often memory is spared, whereas language, judgment, personality may be affected early. And if this looks more like a degenerative dementia, we can talk about differentiating it from some of the other common ones, such as Lewy body dementia, vascular dementia, et cetera. But we first want to examine the patient, right? We can do a MoCA or a mini mental or one of these types of tests to get a sense of what the actual deficits are, both in terms of how severe they are. And if this is truly, wow, memory is really affected, but other aspects of cognition are spared, right? What can we dissociate here to get a sense of what regions and networks of regions are involved? And then the next part of the evaluation is going to try to see if there's any reversible causes of dementia, right? So we'll hear the exam and then we can ask you both what, I'll put the question out there to start thinking about, but what are reversible causes of this syndrome of dementia, right? Because once we've diagnosed Alzheimer's disease, there's not really any treatment. Let's not get into aducanumab, right? But I'm not going to call that a treatment for Alzheimer's disease. Lots of people shaking their heads, right? We won't get into that, or we'll be here all day discussing it. Frontotemporal dementia, no treatment, right? Lewy body dementia, no treatment, only symptomatic management. So we really want to find if there's some type of reversible cause, and we'll talk about what that differential is after we hear the exam. So Marie, why don't you tell us the exam, and then Saki will have you discuss it, and then the three of us, we can talk about what we're thinking is going on and what tests we'd want to order to look for reversible causes or whatever we think the final etiology is likely to be.
Yes, perfect. So let me look for it. I'm sorry. So physical exam, vitals, normal. She was she looked okay, like normal health for somebody her age. Everything systemic seemed normal. For neurological, she didn't have like any sensory, motor, or cerebellar deficits. So they did a mini mental test, and I'm gonna try to like describe it for you because if not, it would be too easy. So they asked the questions for time. She could only respond year, season, and date, but not the day or the month. So 3 out of 5. They asked orientation to place, but she could only answer the state, the country, the city, but not the hospital or the floor they were at. So 3 out of 5 as well. She was given 3 words, and then she could register them appropriately. So 3 out of 3. She was asked to count backwards from 100 by 7s. She could only count up until 79. I don't know how many. So 93, 86.
That's pretty good, yeah.
Afterwards, she was asked to name the 3 things, and she could not name either. So 0 out of 3. She was giving a 3-step command, and she could follow it. So 3 out of 3. And then she was asked to name, I don't know what they asked, like 5 simple objects, and she could name them. So 5 out of 5. She was also asked to copy the picture with I don't know how, I don't even know how to, what's the figure.
Pentagons, interlocking pentagons.
Pentagons, that's right. So, and she could not do it appropriately, so they gave her 0 out of 5. Total score was 22 out of 30. 22
out of 30. Okay, and the rest of the exam, systemic, neurologic, nothing.
Yeah.
Okay, so we just, we're in the neurology clinic, right? We haven't heard any murmurs, rubs, gallops, crackles, no ascites, none of that stuff. We're just here with our friend, the nervous system. So Saki, what do you make of this mini mental status exam based on the pattern of thing, or what's not working here, and what are you finding? How would you interpret it?
So from the MMSE, since the systems examination is essentially normal, looking at the MMSE, she seems, this is a woman, right? I thought, yeah, it's a woman, yes. So she seems like she's just not very alert about exactly where she is and exactly what time it is, which is honestly not that bad for an 82-year-old woman, I mean, if you're at home the entire day, we would forget days and dates. So it's okay if she knows which month she's in. Hospital, yes, a little bit. I mean, I would know if I'm in the hospital or not. She doesn't. Apart from that, I think she has significant anomia, like problems with naming. So anomia, I think, which shows temporal lobe, like a temporal lobe involvement, because she couldn't name any of the objects. She was alert and did do everything that was asked. She did her commands were fine. She calculated fine, which is great, up till 79, I think she said. So those are fine. So the only thing I see is significant temporal lobe involvement, which goes with early onset. I mean, I don't want to diagnose her just off yet, but it goes with early onset Alzheimer's dementia. And one thing
go ahead. Yeah, sorry, go ahead.
One thing that I just wanted, I just wanted to, put it out there is I wanted to ask, I know this is someone else's case, but it's important to kind of ask if she feels that she has loss of memory as well, because typically with these kinds of dementias, the family members are more worried about, and the patients are like, oh, I'm fine, I can do everything, and they don't know me and all of that. So yeah, that would be an interesting thing to ask her. Otherwise, it's subjective cognitive decline versus minimal cognitive. I think that's, so yeah, I think early onset dementia is what I would see. And sometimes, with the physical exam, I would really try and see if there is any signs, any form of tremor or mild, reflexes, because vascular dementia can also have hypo and hyper. So yeah, but she's saying it's essentially normal. So yeah, just early onset Alzheimer's, I think.
Yeah, great thoughts. Maria, I might have missed this. Did she have difficulty naming the objects or just the memory test? Or?
She could name the 5 random objects, but she couldn't name the 3 objects that were given to her. So the 3 words.
3 words, I see.
Language was okay, but recalling the words that it was given to her, that was where she scored 0 out of 3.
I see. Yeah, I was confused on that also, Saki. No problem. Yeah,
sorry.
No, sorry. Nope. I think you were saying that she didn't remember couldn't name the 3 objects in the memory test, meaning that was the memory, right? So that was perfect. Thank you. Okay, great. So right, the patient's a little bit disoriented, but if you work from home during COVID, right, or if you're a resident, you just know to show up every day, right? You can lose track of what day of the week, and sometimes the date even. We would ask the patient, and we're all looking at our watches to see if that's right or not, right? So, so there is that. I know it's Tuesday because I'm here, but if you push me on the actual date, I might lose a point there as well. So the real issue here, as you said, is the memory loss, 0 out of 3. We don't know this from this. Maria hasn't tested the patient, right? She's reading the document here, but if you use red window and honesty, right? Those are the 3 words I use because they're hard to. Some people will say, blue ball something, and then blue ball kind of is easy to remember as one thing. So red, I guess you could have a red window, but not that easy of an association. But you use those, and sometimes the patient, you said, do you remember those words? Sometimes the patient says what words, they don't even remember, that episode of that exchange. But if they say, oh goodness, I was worried about this part or whatever it is, you give them some time, but then you can say, well, one of them was a color, and see if they can get it. And if they still can't get it, was it yellow, blue, or red? And then see if it was red. Are they guessing, or does it actually trigger something that was in memory and they had trouble with retrieval, right? So the storage worked and retrieval was impaired. Window, you could say it's a part of a house, right? And then you could say, is it door, window, or wall? Wall, yeah, no, so they didn't store it, can't retrieve it, right? Or you don't know if they can retrieve it or not because the storage was not there. Honesty, a characteristic you might like to see in a friend, is usually how I present that one. And then if they can't, I say loyalty, honesty, courage, right? And see if they, was it stored even? So sometimes, and the MOCA test, which I like a little better than the mini mental. So the MOCA is available in, I don't know how many languages, but many languages. So that's helpful if you speak another language and can test the patient in another language. But that has in the little memory part, the points that you get for remembering. And then I think they changed it recently, someone showed me, but you can say for category Q and for multiple choice to at least get a sense of if it was 0 out of 5, was it 0, 0, 0? That means the memory is really impaired. And again, particularly recognition, episodic memory, this temporal lobe.
But I had one question on the MMC that you were asking. So if you give them hints, you still have to give them 0 for that, right?
Yeah, so the mini mental, I think, is just recall. But if you look at the MoCA, it has a little grid there where you have, word recall, category Q, multiple choice. And it used to be you still get however many you get, it's more for you to see and follow over time, are those other parameters there. But I think someone showed me either another version of the MoCA, there's several versions, or I might be misremembering that. There's some scoring where you can get maybe some partial credit for those other ones. Okay, so you said if this is really, and the other interesting point you made I wanted to touch on was, do we know, and we don't know because this wasn't a patient any of us saw, was the patient concerned or the family member brought them in? And you're right that in many cases of dementia, the patient has been brought in by family members and is not necessarily that concerned with their deficits. Although there is a growing literature, and I think it's some of your friends there in the cognitive division at Mayo, Saki, who are writing about subjective cognitive concerns, because the old teaching was if a patient comes in and says, I'm here because my memory is terrible, doctor, and you say, well, you remembered to come to this appointment on time, and you drove here, and you parked, and you found my office, right? That looks pretty good. That there is an emerging literature that there may be something more to subjective cognitive concerns, that they may be sort of not always, but have some more than 0 predictive value of potential cognitive impairment later. I'm not up on this literature. I've just seen that sort of old teaching of subjective means it's not going to pan out on exam and it's just anxiety or something. And that the patient is brought in by someone else, that's definitely dementia, that it's like everything in medicine. Once you peel the onion a little bit, it's a little more complicated. So right. So if this patient really has years at this age of progressive memory loss and isolation, and perhaps some navigation difficulties, we would certainly think about the diagnosis of Alzheimer's disease. You said early onset. I want to just check. I think you meant early Alzheimer's disease as opposed to early onset. Yeah. Just to clarify, I think that's what you meant, and just to clarify for everyone, early onset would be less than 65 or something like that. But early in the disease, and that she just has memory impairment. Although the mini mental it's mini, right? And it's in the office, right? So we tested subtracting 7. We didn't test managing her finances, right? So sometimes people can do reasonably on there, and the MoCA at least has an adjustment for how many years of education the patient has, right? So you have to keep in mind, right? Someone who is, a professor of theoretical physics who says, I'm having a little trouble, doing my job, and you say, look, but you're doing all this other stuff, right? That noticing 1% of 1,000, right, is different than 1% of 100, right? So on the other hand, people with a lower level of education or a less cognitively demanding but equally important job, right, may have a further decline before they notice a problem if they're not taxing, if their job is not taxing their cognition as much as other aspects of the type of work they're doing, manual, physical labor or something like that. So sometimes people come in and they're so advanced and you think, oh my goodness, how were they going on? And everyone thought it was fine and they were just older because they were able to do the things that they were doing mostly. Whereas some people come in and you say, look, you're still the professor of theoretical physics, I think you're okay. And then years later you say, wow, that was maybe the beginning for them. Or they say, I thought it was just, I was getting older, I misplaced a few things. And in retrospect, they realized that was the beginning of a dementing illness. So you're right, it would be hard not to just be thinking of Alzheimer's at this point. We have age, memory loss, probably the first thing that popped into people's mind when we saw memory loss in 82 would be Alzheimer's. But as I mentioned earlier, since that's not a diagnosis we like to make, right, because it's not one we can treat aside from symptomatic management, we always want to look and see if there's any reversible causes of dementia. So how do you, Saki or Kirtan, how do you think about these reversible causes, either in terms of categories or tests you would want to send and what you'd be looking for to make sure we're not missing something we could treat?
Should I go first, or Kirtan, do you wanna
go ahead? No, go ahead, Saki, it's fine.
Okay. So I think the first thing I would do, because the patient is in the office and she has a history of depression, is do the geriatric depression scale. First do the screening, which is, I've forgotten the questions, but one is like, what do you feel? Or how do you feel? I forget the questions, but there are 2 or 3 questions and they're pretty simple. And once the patient kind of says, inclines towards depressive, answers which go towards depression, then you do a full scale. I think that's what I remember. So that's the first thing I would do. Firstly, this reversible causes of dementia would be what I know, depression, hypothyroidism, and a B12 deficiency, if I'm not wrong. So these are the 3 things that I can think of. And in that case, her, because she has a history of depression, I would be more inclined towards depression. But still, if she's in the office, I would like to get blood work done for thyroid. And I would also ask her questions if she has constipation or if she's feeling too cold, those questions. Many times they take the levothyroxine every day. So sometimes they even forget to say that they take it because they've been taking it for so long. And this has happened to me. So yeah, that would be one thing that I would ask. And thyroid, and yeah, B12, she's taking her B complex. So I don't know if that would, but maybe sometimes people who have a malabsorption, we might need to maybe get labs done for that. So yeah, these are the 3 things that I can maybe think of.
Fantastic. So depression for sure, B12 deficiency, and fantastic point, right? That this patient is taking B complex, but it's whether they're absorbing it, right? They could have B12 deficiency. Clues could have been if we also found a neuropathy or we found some upper motor neuron signs or both to suggest other aspects of B12 associated neurologic conditions, but you can just have cognitive disturbances, right? We'd want to screen for depression. Then you mentioned hypothyroidism, right? I can't say in all of my years of screening people for reversible causes of dementia that I've picked up a hypothyroid case, but it's definitely in the differential. Yeah, a couple of other tests we would get and things we would look for. Kirtan, what were you thinking of here?
Yes, so basically I was also going to say B12 and thyroid thing, but the sad part is that the examination was totally fine. I was in fact, hoping for something like ascites or efficiency so that I can work my way through, but we didn't find anything. And just last thing that I wanted to mention was encephalopathy. We know that when we consider the diagnosis of encephalopathy, having someone being encephalopathic for 1 year is extremely unlikely. But I just wanted to mention that there are 2 diseases which I remember, which can classically present only with memory loss and no other symptoms. So one of them is Hiv encephalopathy. We know that HIV can cause lots of autoimmune disease. It can cause JC virus infection. It can cause EBV, CNS lymphoma, and all those things. But they would tend to present with other signs and symptoms, probably focal neurologic deficits too. But HIV encephalopathy, if you consider in isolation, which is of course unlikely, but can present in this way. And then syphilis, as we always worry about that, what can syphilis not do? It can do anything. So syphilis encephalopathy is something also I wanted to make sure. And then just lastly, maybe I would do fundoscopy to make sure that ICP is not traced in any way. And then just briefly to touch on this mini mental state examination, we discussed on a few VMRs back that Broca's and Wernicke's aphasias are one thing, and then there are neurodegenerative variants of aphasias. So in Alzheimer's, classically, we see logopenic aphasia. Sometimes the comprehension is not intact. The patient knows how to pronounce the words and everything, but the comprehension is lost. So I would also like to make sure that we look in for that in detailed manner so as to make sure that patient doesn't have logopenic aphasia. If the patient has, then it can increase the suspicion for Alzheimer's disease. And vascular dementia too is something we should discuss. Now we know that usually on steps we learn that it present in a stepwise deterioration, but Aaron always teaches us that it can present in a similar manner to Alzheimer's and everything, just gradually progress to dementia. And the patient already has got CABG, triple vessel disease was there. We know that atherosclerosis and all of them are systemic disease. So maybe the patient also has carotid atherosclerosis and all those things. So although Alzheimer's seems the overwhelming possibility, but just to check our bases, we need to make sure that vascular dementia, logopenic aphasia, all these nutrient deficiencies, and any component of encephalopathy by looking for infections, we are not missing them. That's my thought.
Yeah, fantastic, Kirtan. Yeah, so I think I believe someone can tell me who's internal medicine or infectious disease. The CDC guidelines are basically the reason to screen someone for HIV is anytime a patient presents to a healthcare facility, right? So that you don't miss it, and because it can be either silent or present in so many different ways. The terminology is confusing: HIV encephalitis, HIV encephalopathy, HIV dementia, HIV-associated neurocognitive disorder. I believe the standard terminology now for a dementia that is caused by HIV infection without superimposed opportunistic infection, it's just the HIV virus causing this, is HAND, HIV-associated neurocognitive disorder, which is divided into mild, actually I don't know what all it's divided into, but the mildest one is only detectable in the lab, and then there's one with identifiable cognitive concerns for the patient, and then there's full dementia. Usually patients with that, it's a very advanced AIDS by the stage they've developed. This is not someone who looks healthy and has subtle kind of memory disorders. They often also have HIV myelopathy, and they are generally very ill by the time they've developed AIDS-associated or HIV-associated dementia, or HAND, as it is now called. Syphilis, always on the list. For those of you who have heard Doug Pett stump me on the consult question podcast, the one diagnosis, I didn't mention the entire 2 hours, which was edited down to 1 hour for podcast consumption, with syphilis, and that was the diagnosis in a patient with radiculopathy and cranial neuropathy. So yeah, syphilis, we have to screen for that as well, as you could get what used to be called general paresis of the insane, obviously not a way that we say this anymore, but a dementia associated with syphilis. And then I think the other important thing here, as often in neurology, right, is neuroimaging, because every once in a while you'll get a surprise that this patient has a huge meningioma pressing on the brain, and they've developed a dementing syndrome from a very slow developing tumor, and you take it out and the patient improves. I've seen patients who present with a seizure, and in retrospect, they had been diagnosed with depression for years. Their personality had changed, and there's just a huge meningioma there the whole time. Subdural hematoma be another sort of reversible cause, normal pressure hydrocephalus, or just hydrocephalus from a tumor or something like that. Although hydrocephalus evolving over a year, again, it's possible. Yeah, it is possible. So I agree with you. A lot of signs are pointing to Alzheimer's, but before we would say that definitively, we would want basic labs. Also, what if the patient has undiagnosed chronic renal failure or hepatic failure, right? And has all the bad humors that the kidney or liver are not doing their thing to, their internal medicine thing to make those bad humors not affect the brain, right? Presumably the patient would have a more global encephalopathy, but things we would not want to miss, and then some type of neuroimaging. You mentioned vascular dementia, and I'm glad you keep perpetuating this point, Kirtan, that if you're taking step one, right, it's stepwise, the patient gets a little worse every couple of months, but in real life, how many scans have you seen the report say chronic microvascular disease, periventricular white matter changes, right? And those are silent infarcts, right? And the development of those silent infarcts over time can lead to a progressive dementia. Usually, the vascular dementia patients are going to have a lot more deficits in executive dysfunction out of proportion to memory, sort of slowed cognition, deficits in attention. And often, because there's so much subcortical white matter disease, you'll get some brisk reflexes or upper motor neuron signs or other spasticity or other clues that there's been vascular insult to the brain. And every once in a while, a patient, you just find a stroke in the hippocampus that maybe happened acutely and nobody sort of noticed it. And that's called a strategic infarct, where either a stroke of the thalamus or the hippocampus gives, or a couple of regions sort of step-by-step disrupts enough of the underlying networks that the patient has a syndrome of dementia, but from vascular etiology. So stepwise is one possibility, in my experience, the least common. There's strategic infarct of a sort of key structure for cognition. And then there's the more chronically progressive vascular dementia. And all of this has gotten so complicated, right? Because we have learned from autopsy studies that we are not that great at diagnosing these conditions during life. It doesn't correlate that well. And that's why these clinical trials are so hard to do. We need to figure out when these patients are first starting before they're even symptomatic, because by the time they get to us, we're not that great at diagnosing them, and we're getting better with amyloid-labeled nuclear imaging studies and CSF biomarkers of A-beta 42 and tau ratios. But many patients on autopsy have some amyloid and some tau and some vascular pathology, or some Lewy bodies and some Alzheimer's. So I think we're not at a great stage really of truly understanding how these diseases work. And that's why we've been had so much difficulty finding appropriate therapies, because a lot of patients have mixed pathology, and even the pathology, are those amyloid plaques causing the disease, or that's just some sort of byproduct of the underlying process that we don't understand yet. Even the amyloid hypothesis itself gets hotly debated at meetings, hence all the controversy around aducanumab that clears this biomarker, but doesn't clearly make people any better. And what does that actually mean for Alzheimer's disease patients, the amyloid hypothesis, et cetera. Okay, I've banked on, with 1 minute left, that the answer will be straightforward and not like last week where Doug Pett had 4 more aliquots for us and we had a diagnosis of Balamuthia mandrillaris, granulomatous amoebic encephalitis, and we were here for 2 hours because we kept getting more data and saying, wait, what? Wait, what? You got a biopsy? And it was, wait, the pathologist pulled the biopsy and reinterpreted it. I'm going to bank on it, that not being the case today, but I maybe did not bank well. So I'm going to presume this patient got some labs and some imaging. And if our hypothesis, Kirtan and Saki, is correct that this is Alzheimer's, what would you expect to see on neuroimaging?
So Kirtan, do you want to go first?
Right, yeah, sure. So of course, as Aaron mentioned earlier, that we would like to see some sort of atrophy. I mean, if it has been really going for 1 year and the patient has been symptomatic for 1 year, what if it had been going on for, quite like 2 or 3 years before that? So by this time, maybe we would expect to see temporal lobe atrophy, maybe a little bit of parietal lobe atrophy too. And we can, apart from imaging studies, we can look for CSF studies too. If the suspicion is so high that if it is indel Alzheimer, then we can look for this tau protein, then amyloid protein. And apart from that, we will like to see ventricles, because if ventricles are dilated, then as we discussed earlier, what if the patient has hydrocephalus, which has been silent for entire year? So we would like to see the ventricles. Then of course, mass lesions. We talked about subtural hematoma. We also want to look for meningiomas or anything like that. And of course, strategically placed infarct too, we would like to see in limbic system or something wrong with the temporal lobe. But it is hard to fathom that the patient has isolated memory loss and nothing else. So there are not many clues that we can derive from imaging studies. And what can be the suspicion for doing imaging studies in the first place? Because this is also something which bugs us on examination. In the step 1 and step 2 exam, they always ask that what is the next best step? You just give the medication and send them home, or would you go for imaging studies? So what's that threshold after which we go for imaging studies in the first place? So that's really interesting.
Yeah, that's right. I think we would want imaging studies both here to rule out potential reversible etiologies, and also, if not, to see if there's a particular pattern of atrophy that aligns with our clinical suspicion. And that's right, we would look for medial temporal lobe atrophy, and this is often symmetric. So if you don't look at a lot of scans, you're looking back and forth, it might not look abnormal. You have to get a lot to get a sense that the temporal horn of the lateral ventricle is usually just a tiny slit there that will look very large, and the medial temporal lobe will look very thinned out. Often there's superior parietal atrophy as well, out of proportion to other things. And the ventricles, Kirtan, are tricky because as the brain atrophies, the ventricles kind of expand to fill that space, hydrocephalus ex vacuo. And countless times we get referrals where the radiologist says, cannot rule out normal pressure hydrocephalus, clinical correlation is advised. And the patient has no gait difficulty, has no, urinary incontinence. Sometimes these patients even go right to the neurosurgeon and get their shunt, and they don't get better. And the neurosurgeon asks why, and we say because they have Alzheimer's disease. They just have big ventricles for another reason. There are many biomarkers for what the ventricle, how to measure the ventricles suggest that this is NPH. We won't get into those today. But I think, yeah, here, if we saw a scan that was very suspicious, everything else was ruled out, probably wouldn't proceed to the spinal fluid and biomarkers. That's something we do when it's ambiguous or the patient might be getting enrolled in a clinical trial, or sometimes patients who are very early in the disease, you have a strong suspicion, they're saying, should I retire now? If this is Alzheimer's, I'm going to retire now. Then you say, well, let's get one more piece of more definitive evidence and be looking for A-beta 42 and tau in the CSF. But probably in a classic case, once the imaging is consistent, we would probably stop there and cancel and think about what services this patient will need. And these medicines that are not very effective, the acetylcholinesterase inhibitors, donepezil, et cetera, that very marginal benefit. Sorry, drug companies, but that's most people's experience. But often they will be offered and patients will want to have them, maybe slight decrease in the rate of decline of memory for these medications, but not particularly impressive. Okay, Maria, what happened next? And did you send Balamuthia serologies, and are we going to be tricked like last week? Probably not.
No tricks here. So white blood cell count and CMP was all normal, TSH normal, vitamin B12 normal, AUA was also done and it was normal, RPR negative, no HIV. So something to think about after your discussion. And they did a CT without contrast, no intracranial abnormalities. Mild generalized cerebral atrophy with small vessel disease in the supratentorial white matter. That's all I got.
That's it. No MRI?
No MRI, just a CT without contrast.
Okay. Any further thoughts, and we'll wrap up?
I had a question actually. So what would be, I mean, all these patients should ideally be getting an MRI, correct? Because except for the subdural hematoma and I think a big mass lesion, everything else would require us to have an MRI, correct?
Yeah, I would agree with that. If for some reason the patient is so confused that they won't tolerate the MRI, or they have a pacemaker, or have been exposed to metal work or shrapnel or something, generally you could get a pretty good sense of a pattern of atrophy on a CT without contrast. If the patient is this impaired, sometimes the way I think about it, MRI, you could find subtle, smaller lesions, right? With contrast, you could find some small enhancing lesion, or maybe the meninges are enhancing and an inflammatory chronic meningitis. But in a case like this, I think you would, sort of know what you're looking for, right? And if the patient is this impaired, it's not that you're going to miss some small lesion, you're looking for something bigger. So hard to know if a neuroradiologist read this, or this was just overnight, on-call radiologist, chest radiologist said, looks pretty good, a little bit of atrophy, and didn't have the nuance a neuroradiologist might say disproportionately in the temporal or parietal lobes. So probably we would want an MRI, but Maria said she's not going to give us one. And in some regions of the world, maybe a CT would be all you would get, or maybe you wouldn't even get that, and you would get your labs and you would follow the patient and see if anything comes out that makes you say, oh, I should have thought of this and it's treatable, or say this sort of looks degenerative, we don't have proof. But we wouldn't have enough information based on that CT report, although we don't know what it looks like to call this officially. So what, Maria, what is there a final aliquot or just the presumptive diagnosis?
That's the diagnosis. Do I go ahead?
I think go ahead and either tell us we've been on the right track, or we're completely off.
Yeah, so of course we've all been on the right track. It was probable Alzheimer's disease. She was started on aducanumab. No, I'm just kidding.
Okay.
Milligrams at that time, which was later changed to a morning dose due to vivid dreams. Her dose was increased, but no improvement on her Mini-Mental test at 3 months. And 1 year later, her Mini-Mental test was 18 out of 30. She had stopped driving completely.
People generally say that the normal progression of Alzheimer's disease is about 3 points on the Mini-Mental per year, give or take. But if it's going faster than that, that is atypical. And we mentioned Creutzfeldt-Jakob. Obviously, this doesn't look anything like that, slowly progressive, kind of isolated to one domain. But in the differential for that, and a lot of the patients that go to autopsy, people thought they had Creutzfeldt-Jakob before we had better biomarkers. One of the highest misdiagnoses, there's a series from Case Western, probably about 15-year-old series, was atypically rapid progression of a neurodegenerative disorder. So patients that had their Alzheimer's disease just went really quickly. And there's obviously a bell curve to how fast people progress, but this is sort of the normal tempo of about 3 points of loss per year. It can go faster, and that would be a red flag for thinking about other things, but can also be part of the diagnosis. All right, well, fantastic discussion, Saki, Kirtan. Thank you for presenting this case from Human DX. Maria and Valeria, do you want to close us out with some teaching points here?
Yeah, great discussion, everyone. Sorry, I give you maybe an easy case for the people that discuss that are just brilliant. But so the chief concern was memory loss. And the first point that Saki mentioned was, who is a patient? and the age was a key point in this discussion. And then we use Aaron's equation with this tempo or time onset and localization. And tempo is queen, so we should consider in the hyperacute category vascular etiologies. Saki mentioned acute etiologies such as toxins, infections, and metabolic causes, and subacute and chronic etiologies such as inflammatory diseases, encephalitis, autoimmune causes, or age-related memory loss, or dementia and depression. And then in the localization, we were thinking about the two presentations of memory loss, so loss of episodic memory, in which we will think about something affecting the temporal lobe or the hippocampus, and then working memory. And Aaron mentioned a great pearl, which was that you cannot test memory if there is attention impairment, because the patient may have a good memory, but just because they were not paying attention, you cannot test on the physical exam. And Kirtan gave us a really good differential on episodic memory impairment by localization, etiologies such as herpes simplex that has tropism for the limbic system, and MNDA encephalitis as well. Then also Creutzfeldt-Jakob disease, which is a rapid onset, usually presented with memory loss, but also other signs such as myoclonus. And which is actually the part of, I think, a tutorial by Aaron, the PCA territory, such as a vascular, like a stroke, that could only not present with classical signs that we associate with posterior arteries, such as the occipital lobe being affected, but also it gives irrigation to the hippocampus and part of the thalamus, so you can also have memory impairment in that case. And then a new diagnosis in the differential was transient global amnesia, which is usually a sudden loss of anterograde memory, and the patient classically keeps asking the same question over and over again because they cannot keep making new memories, and can be triggered by an emotional event. And then our differential toxicities causing memory impairment were B12, B1, and B3 deficiency, copper deficiency, and also on the chat I picked up some good pearls about zinc ingestion leading to copper deficiency, and also cobalt toxicity associated with hyperesthetics. And then our differential of dementia was divided in two categories: the reversible causes, which should be ruled out first, such as depression, hypothyroidism, B12 deficiency, and neurosyphilis, and the reversible causes such as Alzheimer's, vascular dementia, frontal lobe dementia, Lewy body dementia, and HIV-associated neurocognitive disorder. And so that was all for today's case. Thank you so much for presenting, discussing, and hope to see you tomorrow and next week as well.
Great, thank you so much, Valeria. Thanks again for coming up with this case from Travis's collection. And Saki and Kirtan, brilliant discussion. Thanks for volunteering on your first VMR, Saki. Come back anytime and practice your neurology. Did a great job, as did you, Kirtan. And everyone else who was there and who is now leaving, you can always try next Tuesday. You saw how much fun we had. Please consider it. And if you have a case, please feel free to bring it for one of the future sessions. Thanks, everyone. Have a good day.
Thanks.
Night.
Bye-bye. Thanks, Anna. Thank you, yes. Loved it. Bye-bye.